we have 3 members of the panel. All of the members of the panel have a background both in regulation, but also in additional hat, if you like. And this kind of really reflects back on what in one of my earlier slides earlier this morning, in which I said that sort of many of us have many different hats in the as agents of quality. This sounds very loud to me still. Is it acceptable? No. Okay. So firstly, Dr. Deirdre Madden, who's a member of the Medical Council and who's also a senior lecturer in law in UCC, and also was the author of the Madden Report. Next to Deirdre is Dr. John Jenkins, who's a member of the GMC, and he is the chair of the postgraduate board. He's also a medical practitioner. In his sort of clinical work, he works as a pediatrician. And then on John's right is Margaret Murphy, who's also a member of the Medical Council, and she's also a patient advocate and external lead for the WHO Patients for Patient Safety Programme. So the structure of this Moral May session is that we have a number of vignettes, a total of 4 vignettes in all, and in your packs you'll see that these sort of case vignettes are in each of the in your packs, and so we're actually going to take them in order. And the order of the session is that so we will take each case one after the other. And initially, I'll just give a brief summary of the case, and then I will then call, so I won't read the full details of the case out because they're in your pack. So as I'm talking, you can probably start reading case 1. I will then call on members of the panel to give their own views from each of their different perspectives, and then I'll invite comment from the floor before sort of summarizing our discussion. So the first case then is the case of Alex, who is a 22-year-old man who has moderate learning disability. He's also got a number of problems, including type 1 diabetes mellitus. He needs support from his mother, both in terms of management of his diabetes, in terms of his diet and his insulin injections, but also more practical things relating to making sure that he attends for appointments, because he has a tendency not to attend unless prompted. The ethical dilemma posed in the vignette is that although for over many years Alex has had a good relationship with his mother, they have just recently had a falling out. And as a result of that, Alex has moved out of home. There are then ongoing problems with really management of his diabetes, particularly in that he isn't adhering to his diet, and he isn't monitoring his diabetic control. And you, Dr. O'Grady, who obviously is this GP, is the doctor concerned, and he has a dilemma as to how to manage this problem. So perhaps I could call maybe on Dr. Madden first to offer her opinion as to what, if anything, Dr. O'Grady should do in these circumstances.
Thank you. Well, I suppose just to start with, obviously this is a complex, though probably relatively common scenario in that for the doctor there has to be an assessment of capacity of this young man in light of his intellectual disability, his own comprehension of his condition and the therapy that's been advised for him. The doctor will have to assess his best interests, his expectation of confidentiality and so on. So it's about balancing respect for Alex's autonomy with protection of Alex's best interests. So we've heard a little bit this morning already about the importance of trust, not only the importance of trust between the public and the profession as a general concept, but also, of course, the relationship of trust between the individual patient and their doctor. And I think we start from that concept, I suppose, in this relationship between Alex and Dr. O'Grady, that trust between them is crucial. So we would start with the presumption in any case of any adult patient that Alex, like everybody else, is presumed to have the capacity to make his own decisions in relation to his treatment and care. And up to now, Dr. O'Grady's been able to facilitate that in that Alex has being able to make decisions about his own care in conjunction with and with the support of his mother in a lot of cases. So that's the starting point. And then if Dr. O'Grady is concerned about Alex's capacity to understand, he might look, for example, at the Medical Council's guide in relation to assessment of capacity, looking at Alex's level of understanding and retention of information about his condition, his ability to apply information to his own circumstances and come to a decision and to communicate that decision. But also, of course, he has to consider whether serious harm would be caused by the course of action that Alex is now sort of embarked on. He should encourage him as much as possible to involve his mother if he considers that that's in his best interests, which it would appear to be. And ultimately decide on the basis of capacity that if Alex is capable of making his own decisions, that Dr. O'Grady should encourage and support him to do so and try to facilitate his understanding of the importance of compliance with his treatment regime and so on. And if he considers that Alex lacks capacity to make healthcare decisions, then disclosure to his mother might be in his best interests. And that's something that he would have to consider based on his assessment of capacity.
Deirdre, thank you. Could I maybe pass on to John next, and John, to give your perspective?
Thanks, Kieran. Good morning. Whenever I was looking at this case in preparation for today, I was reflecting on my own time as a paediatrician. And for part of my career as a paediatrician, I looked after all of the children in our area with diabetes. And although it's not a direct parallel, because most of them were children or young people, but some of the principles I thought were still applicable to this. And one of the things I think I learned over those years was, as it says in the old aphorism, there's no point winning a battle if you lose a war. And maintaining that trusting relationship, which Deirdre has emphasized, I think for a doctor in this is what I would see as an underlying principle. And whatever action the doctor takes and whatever priorities the doctor brings to the individual patient's situation, I think it's important to keep that in the back of their mind. The best they can do for this individual is to maintain that relationship of trust. It may require there to be a period during which the actual care that that person provides for themselves is not what the doctor would wish, but ultimately, if they can engage with that person, then there may be an opportunity to actually get that back on the rails at a later stage. Now, having said all of that, my only other comment at this stage would be that I think it's very important that each of us as a practitioner keeps very careful records of our decision-making in these circumstances. And if we are in doubt, and again there are issues about seeking external involvement or disclosure without consent, then seeking advice from a colleague or a defence association or indeed from the council, I think are other things that would need to be borne in mind.
John, thank you. Margaret, can I ask you to comment on the case?
Yes, well, not wishing to duplicate anything that has already been said, it would be very easy to look on this as the black and white situation and just say, yes, the ethical guide says you respect the patient's wishes and therefore you exclude the mother and all else. But there is common sense, and that brings in then a grey area. And I think there's a real role for the doctor here in helping this young man in his own level of awareness around his own vulnerability in his particular situation. He has now made an impulsive decision which may impact really adversely on his safe care going into the future. And I think there's a role for the doctor here in actually partnering in a very real way with the young man himself in help and impressing on him that up to now the two people who were most interested in him living a safe life with his condition were the doctor himself and his mother. And I think there is what has now come into the equation is this unknown quantity of the new friends, and I think the doctor could possibly help him test the capacity and the willingness of those new friends to be a support to him, because probably in the long term that might actually be a good thing for the young man himself to arrive at a more independent situation, and that could possibly be arrived at by he persuading the young man is not to go the whole hog, as it were, but to do this on a phased basis. Have your mother involved 5 days a week, your friends 2 days a week, and then progressing and see how that might come out. It might be a practical solution, but again, at in the last analysis, the doctor's duty is to mind the young man himself and to do whatever is necessary to keep him as safe as possible.
So Margaret, thank you. Are there comments that people wish to raise from the floor on this particular vignette? So perhaps there's a microphone. Yeah, it's the gentleman here.
My name is Liam O'Brien. I'm a GP. I would probably try and bring the mother and her son together with myself, and we would discuss it jointly with his permission.
There's a question here, I think.
Yeah.
I'm Irene, I'm from the State Claims Agency. What comes to mind, I've got a brief to work with disability providers who provide services to persons with disabilities, and they have developed terrific methodologies to support a young man like this in finding his own feet. And I suppose what came to mind, just some thoughts, who else is involved in care? Because my understanding is there are also bouts of depression and there's some binge drinking and stuff going on. Because as a mother of a son myself, who's maturing, who's 24 and trying to find his own feet, I suppose there comes a point in care when we do need to step back a little bit and help this young man to find his space, and we're not always the best people. So we can be kept in the picture, but I'm kind of thinking advocacy is what I'm thinking. I'm thinking of the kind of buddy systems that they're putting in place in the disability sector to decongregationalize people, does that make sense, and move them into the community. And I think those supports are very, very available in Ireland. And I suppose I'm kind of thinking of team here, a team approach, and maybe we can pull in, I think Margaret addressed it a bit with buddies and friends, but I think we need to, on the whole, a young man like this trying to live independent will need a kind of community. And so the mum will have a role, but this may be a point of where he's trying to make an issue. So maybe better not to rub it in, so it's kept there. But I think you'd work on a buddy, kind of a buddy advocacy system. And other professionals, maybe a mental health issue, or the diabetic nurse specialist who may be able to support this conversation, this new phase that this young man is trying to struggle to enter into that isn't uncommon at all. Thank you very much.
Thank you. Are there other comments or questions on the vignette? Question, Dr. O'Dowd, Professor O'Dowd.
Could I just ask for information? Are these cases that have come to the attention of the Council, or are they from clinical practice?
No, so these are cases that have been constructed to illustrate an ethical dilemma.
Dr. Peter Walroop, General Practitioner. Could I just ask that the panel might consider, if on assessment Alex does not have capacity, what are the options?
So that's a good question. So as this is a question to the panel, I think perhaps I might, as Dr. Madden seems to be opening up her ethical guide, maybe I'll ask Dr. Madden to provide a response in the first instance.
You can always rely on the guide to have the answer. So basically, what the Council's guide says, that if the patient lacks capacity in your assessment to make a healthcare decision, the guide advises that firstly you find out whether somebody else has legal authority to make decisions in relation to that person. That person might, for example, be a ward of court. There might be some form of legal decision making in existence in relation to the person. So that's the first step, I suppose. And more commonly, that would not exist in many cases, unfortunately. I suppose there isn't sort of clarity around decision making from a legal perspective in a lot of those sorts of cases. So then it falls to the doctor to decide what is in the patient's best interest. So in looking at that, they would obviously have to look at the clinical issues firstly, what treatment is going to provide the best clinical outcome for the patient's own wishes, both in the past and currently, to get a complete picture of whether this is as Margaret called it, a sort of an impulsive decision perhaps, and maybe doesn't reflect the sort of continuum of wishes of the patient. Look at whether the patient's capacity is fluctuating or whether it's likely to increase again in the future. And you may be able to do, as John said, maybe to accept that maybe optimum care isn't achievable at the moment, but that perhaps if the patient's capacity were to increase again in the future, that maybe you could get back to a more regularized treatment regime. You could look at the views of other people close to the patient to look at how they would depict the patient's preferences and values in that instance. And then also perhaps seek advice from other colleagues and other professionals. But ultimately, as the GP with responsibility for this patient, it falls to you to decide what is in the patient's best interests, and to be, I suppose, to be able to defend that decision if called upon to do so.
Are there other members of the panel who wish to add anything further to that? Margaret or John?
Well, I absolutely agree with all of that, and certainly the guidance that the GMC has for UK doctors would be very much in line with what your guide says. And one of the principles is always, if you do have to step in and make decisions on behalf of someone, to make those decisions so that they're least restrictive on the future choices that that individual may be able to make for themselves in the future.
Stephen, maybe do you want to wait for the microphone, Stephen?
My apologies, I missed the opening part of the debate here, but just from the piece I've heard, I think the challenge here is to how can you enable this young chap, Alex, to consent to getting additional supports if it's explained to the patient that there are problems with the inconsistency of compliance. Because on the other side of this, and you may have already touched on it, there are many people that have absolutely no learning disabilities, and they don't want to have anybody in their family or whatever to know about their care, and they're totally inconsistent with their compliance on whatever their therapies are. So there's that sort of reality as well too. So I think it's a question of supporting the patient and to try, where possible, as Deirdre's saying, to enable them to realise that they're not adhering to their treatment. And then the next option is whatever whether it's family or buddies or whatever to assist them. But I think that the focus here should be to try and enable Alex, with his limited abilities, to give his consent to whatever program that they can work out in agreement. Thank you.
Question here.
Jim Gardner. And supposing this fellow arrived at the casualty severely hypoglycemic and dehydrated, and after his beautiful friends had helped him along the way, and what would Dr. O'Grady have to say, or would he have any responsibility for that, seeing as how he's taken over his care?
So would any member of the panel like to take that question?
I didn't quite hear the question.
Okay. So, Etienne, my understanding of the question was that if the patient became severely dehydrated and so became very clinically unwell, what are the obligations for the doctor in those circumstances? Is that what you were asking about? Yeah. So would any of you, John, would you like to take that? Or?
I suppose what I was going to say is that if there's any sort of emergency where the person becomes acutely unwell and requires hospitalisation, and if his capacity clearly is such that he can't make decisions for himself, well then consent from him is not required, strictly speaking, for any legal or for any medical procedure that might be provided to him, because there is a sort of a doctrine of necessity that if treatment is required in his best interests in an emergency situation, then it should be provided.
Well, just to add to it, in respect of another interpretation of your question, I'm not sure whether this was what you intended, but in terms of the GP perhaps being held responsible for the situation having arisen, I think that's why I emphasise the importance of making a record of a decision-making process. Ultimately, it would be up to a panel if that person was referred to the council, for example, or a complaint was made. But I would have hoped that any body assessing the involvement of the GP would take into account if the GP had gone through the thought process that we have described and had sought to do what was in the best interest of that individual, perhaps not being able to control all of those circumstances, at least in the short term, but was able to describe and had a record to demonstrate that they had sought to do that.
Question down here.
My name is Dr. Azam, a pediatrician, Wexford General. In this scenario, I would say, I mean, this child has, this person has moderate learning disability and diabetes, and mom is most of the time looking after. He might be frustrated, he might need psychologist and some other counselor to help also in this situation. So in such kind of patients, I think more counseling and other things we should not undermine also in making the decision, and he might come back after full discussion and full counseling.
Okay, thank you. Over here.
Patricia MacDonald. I'm not sure how to phrase this, but we've heard a lot about the doctor's responsibility. But it strikes me, listening to it as a parent, that that is an individual who's trying to make the move from childhood to adulthood and take his own responsibility for his own illness. And if he decides not to go along with treatment, has he got a right to make that decision? Do we have a right to take that away from him because we have that he's moderately, intellectually, learning disability? You know, a lot of the talk has been about the doctor's responsibility. Do we have a responsibility to recognise a patient's right to make his own decisions? It's just a thought.
So I think maybe, I think it's obviously the key question, if you like. It's the autonomy of the patient and the capacity of the patient to make decisions for himself. But perhaps members of the panel might like to add to that. John, would you like to make a comment?
Well, the only comment I would make is, again, as a paediatrician, I read this across to the situation with child protection. And society is very unforgiving whenever something goes wrong in these situations. So there's a very delicate balance to be achieved between supporting the autonomy. But if it's judged that that person does not have capacity, and sometimes, of course, it has to be a court that makes that judgment, and ultimately, in some circumstances, the doctor may have to seek legal advice in order to make that judgment. But if that is the judgment that is made and supported, then society would expect the doctor to make a decision in the best interests of the patient. But thankfully, that's not often the case.
Professor O'Dowd again.
Thank you very much. It's a very interesting discussion and a very interesting case, and I'm prompted by the last commentator who wanted to know, from what the young man himself wants. Nonetheless, if this young man is admitted, like Dr. Gardner has said, in diabetic coma and suffers a decline in his mental capacity as a consequence, it's very important that I'm a general practitioner from the GP point of view, that the general practitioner has what they call safety netting in place and has a record of the safety nets that are in place and what he's told the mother or told the friends or told the patient himself. And if that, and many general practitioners don't record that, they say they said such a thing, but actually nowadays of the 10 minutes you're seeing a patient, you really need to spend 2 of those minutes or 3 of those minutes actually writing down what you've done, because regardless of what happens, the courts are unforgiving, and when they see somebody, when a judge sees somebody with a terrible injury caused to them, it's inevitable that somebody will be found at fault. And if you haven't got some kind of documentary evidence to say that you put the following in place, which may include, telling his friends to take him to A&E if certain symptoms develop. You are really, I don't know if there are any general practitioners here who would share that view, but certainly Dr. Gardner's question is on the money, and it is our responsibility, I think, to have that kind of record in place. Otherwise, we're in a tough situation, and even more so, the indemnity organisations are in a tougher situation.
Okay, so I think maybe just to summarise then our discussion, I think that the issues that have been identified both from the panel and from the floor, I think, are issues regarding the key question is capacity. Does the patient have the capacity to make such decisions for themselves? I think the challenge for the GP is balancing his assessment or her assessment or his assessment of the patient's capacity with what the best interests of the patient are. And I think that these sort of solutions that have been proposed from the floor really reflect, and from the panel, really reflect, I suppose, engagement. So we've had suggestions that, in fact, that there ought to be engagement with the patient's mother. And also that there should be engagement in actually trying to also look at other solutions to how this patient might be managed. That obviously being with his mother is one solution, but it's not the only solution. And that perhaps harnessing the services associated with learning disability in a way to increase the patient's autonomy, but on the other hand, ensuring that his best interests are served. Okay, so I think that was an interesting discussion. Moving on to case 2 then. So case 2 is Mr. Sullivan. Again, he is an 82-year-old man. He's a member of the travelling community. He's recently had a stroke, and associated with the stroke, in addition to weakness, he has some cognitive impairment and also has some difficulty in swallowing. But in spite of this, he returned home, and his family were actually managing him and were able to feed him with soft food, etc. Unfortunately, what's happened is that over the past week, Mr. Sullivan appears to have suffered a second stroke. This seems to be more severe. He now has more severe cognitive impairment. He has also more severe difficulties in swallowing. It's difficult for the family to actually try and feed him in the way that they did before. And the GP, Dr. Dunlop, sort of wonders whether or not this is a second bleed, which it almost certainly is. And there's a concern as to whether or not the patient would be able to be managed at home, continue to be managed at home, or whether he should go to hospital. There's a division in the family as to some members of the family feel he should stay at home. Other members of the family believe he should go to hospital. This is a real-life problem that happens quite frequently within families, and so we've sort of highlighted this problem just as a way of firstly getting the experts on the panel to offer their views, but also then to hear from members of the audience as to, in your experience, how you would manage this. So perhaps I could start with Margaret first. On this occasion, Margaret, are you happy to give a view?
Yes, indeed. Well, there are a number of issues here as I see them. There are the different perspectives of the members of the family. There you have the daughters who for 2 months have been successfully managing the care of this man at home. They have also articulated his own, what would be his known wishes to them, and because it's the culture of the community, the travelling community, to look after their own, they would not wish to see him go to hospital. And then there is the patient safety issue, where the doctor himself articulates fears, but they're fears which are not yet realities. So I suppose the role for the doctor here would be to try and ensure, insofar as possible, that those fears would not actually become realities. And I think if you were to have a kind of a ranking or a hierarchy within the family, I would certainly be giving greater weight to the 2 daughters who, first of all, have looked after him for that length of time and who are also prepared to provide the ongoing care. But what the doctor needs to do is to assess their capacity to provide the necessary care in a safe way. And on top of that, he could be certainly very helpful in sourcing the local supports that would help, if you like, to make home visits, to train those for initially to be present when the feeding program is happening. So the real role he could play is to, insofar as possible, help that man remain for the rest of his days in the bosom of a loving family and die at home as he would want to do.
Thanks, Margaret. Could I ask John next to comment on the case?
Thanks. Yes, again, just supporting the points that have been made and trying not to repeat them. Obviously, underlying principles are important in all of these things, and I'm sure that we would all agree that the principles of things like dignity and respect and compassion would be the ones that the doctor would be seeking to bring to this very difficult situation. The challenge is working out what those mean in practice for the family and for this individual. It's rather implied here that the individual does not have capacity, but I think that one of the first steps the doctor would have to take is to formally assure themselves as to whether this individual has capacity, and again, as we've talked about, to make a record of the way in which they have made that assessment, and if they are in doubt, to involve someone else in coming to that conclusion, because it would be very important before they then go on to a decision-making sequence if the individual does not have capacity. I think one of the underlying principles that is important for all of us in practice to remember is that good ethical decision-making depends on good medical decision-making. So the assessment of the condition of this individual and whether in fact there has been further bleeding and whether this is likely to continue or whether this is a temporary setback might require the GP to engage with other colleagues to assess, possibly to have investigations. And also for the doctor then, in terms of good medical decision-making, to consider the range of alternatives that there are in this setting, the benefits and the potential risks that would be associated with each of those range of alternatives. And then my final comment at this stage would be just again to add to what Margaret has said about communication, to recognize in communicating with the family and anyone else who's involved the emotional impact that this has. It's not possible for us to just take this as a clinical decision. It's a decision that has enormous emotional impact, and we have to recognize that and be prepared to work through that with the family and possibly suggest to them that they might have some other trusted external people, whether that's a spiritual advisor or someone else who they could turn to and seek to help them as they come to terms with this situation.
Thanks, John. Deirdre?
Yeah, again, without wanting to duplicate, obviously there's the issue of capacity that John has touched on, and looking at trying to ascertain Mr. Sullivan's own wishes, and we have some evidence that Mr. Sullivan himself would want to be at home rather than to be in hospital, and to take account of the family's depiction of what his wishes would be. I suppose ultimately it's a matter for the doctor to decide what is in the best interest of Mr. Sullivan, doing a sort of a clinical assessment and so on. But I suppose what's important is that it's not only the medical interests that Mr. Sullivan has, it's also wider than that. I think it's also about, this is clearly sort of approaching an end-of-life situation, and it's not just about medical interests, it's also about the social interests and the interest that he has in being cared for by his family rather than being cared for in a hospital. So best interest, and what does that mean, I suppose, in the broader context. I think also the issue of communication with the family is hugely important here, because the doctor doesn't want to get caught in the middle between a family that is in some form of conflict, particularly given the trauma and distress that end-of-life situations involve for families. But I think it might be important for those of the family that want him to be admitted to hospital to have, I suppose, maybe a realistic expectation of what can be achieved if he were to go to hospital, because maybe they may be in some form of denial about the fact that their father is reaching the end of life, and they may be under the misapprehension that if he were to go to hospital that he might be saved and might go on to live for many years. And if that's not the case, maybe effective and sensitive communication with them about what might realistically be achieved by hospitalization might help to heal the sort of conflict in the family. Just to pick up on one small point that Margaret made about sort of the family hierarchy and perhaps giving more weight to those who were the carers predominantly rather than those. I'm not sure that would necessarily be a good idea, because I think that might in fact entrench the conflict perhaps within the family if the doctor was seen to be sort of objectively taking the side of one over the other. So I'm just not sure, maybe that's something that we could talk about a little bit more. I think it would be better for the doctor to try to assist in reaching consensus within the family rather than taking the views of one over the other, but that's...
Thanks, Deirdre. From the floor, Abdul, and then over here.
Thank you very much, President. Abdul Bulbul, a retired GP. I'm a bit concerned, and in this particular case, I would leave out the whole issue of the family being a traveling family, because I think, with my experience, that there is a lot of prejudice once you're dealing with a traveler or traveling family, and one's judgment would be impaired by bringing that issue. Whereas I think I was very glad to see that the panel did not mention the whole issue of traveling. They dealt with the case as it merited. So I would just like to make the point that unfortunately in Ireland still traveling communities, there is a huge prejudice towards them.
Okay, thank you. Over here.
Hi, I'm Mairead Murphy. I'm from the Defence Forces. Just in relation to this case, I think as doctors we are very isolated and vulnerable in these situations, that there's a few legal issues wrapped up in this, and I think in a situation like that it might be good to get some legal advice, because if it does end up in court, the legal system will be merciless if we are held responsible for, I'm just wondering, maybe could we get, in a case like this, could we get advice maybe from the Medical Council or from our Medical Protection Society, in trying to reach a professional decision in relation to this case, because as I said, we are very isolated here and it's not just a medical issue.
So perhaps I could take that point just for a moment. I think that the point you've made is actually a very important one, that it's all about seeking advice. You as a doctor should seek advice from a range of different sources, from other colleagues, from on occasion your sort of medical defence, or indeed from the Medical Council. I think that these kind of vignettes highlight the importance of the doctor ensuring that they seek appropriate advice where necessary, rather than feeling that you as a doctor should have to manage this entirely on your own.
I suppose I would just have a little bit of concern, although I am a lawyer, I would have a bit of concern about rushing to law for a lot of these issues. I think doctors are very capable and experienced in dealing with situations like this, and should always just look at the best interests of their patient, taking into account the capacity of the patient, their known wishes and preferences, the fact that this is an end-of-life situation. I would just be a little bit sort of cautious about rushing to sort of defensive practice, which in this case would probably result in Mr. Sullivan being hospitalised, because that might be the safest practice from a defensive medicine point of view, and that may not be what Mr. Sullivan would want or what might be in his broader interests.
Margaret?
And I can actually bring something from personal experience to this, in that I remember within a week or so of my own mother dying, and I have to admit that I was in total denial. And she was living with us at home, and the intention, I expected that she would be sent to hospital. She needed some respiratory assistance. The GP was absolutely fantastic, because what he did was he explained to me, he said, well, she'll go into hospital, they'll relieve her, and she'll be back to you in a couple of days. But again, in a few days after that, she'll fill up again and she'll need to go back, and that will happen again and again. And in actual fact, isn't she really very comfortable here at home with you? So it's all about how the thing is reconciled, how it's presented. And of course, when it was put to me like that, there was no choice. And she did stay at home, and she did die peacefully at home in the bosom of her family. So I suppose that's what you're looking for, is the optimum peaceful leaving of this world for the particular patient. But what does disturb me is the degree of variability, and that was mentioned this morning. There is huge variability in how these things actually play out, depending on the doctor-patient relationship. It's the variability, it can be a huge issue.
Dr. O'Hare.
Danny O'Hare, I'm a member of Medical Council. In the introduction to the case, it says that the family is quite large. So I would guess, say, 8 people, given we're talking about Ireland, and that 2 only of the 8, or in other words, a minority, of the family want a particular action, the inference being a majority of the family want a different action. To what degree should that be taken into account, and is it a telling matter in terms of majority versus minority view?
So just to understand the question, is it the fact that only 2 members are having strong views, or is that your question? That
yes, it says that Mr. Sullivan's other adult children, which I take to be a number greater than 2, wish for a different action to be taken. So to what degree should that be a telling issue in terms of the decision to be taken in relation to the patient?
So that's a very important question, and I think it is one that sort of frequently occurs in clinical practice. So if you have larger families of which there is a division, if you like, in the family with regard to the numbers of the siblings, etc., who wish to take course of action. Deirdre, do you want to make a comment on that?
I think that's really important, actually, because as I was saying earlier, I think it's very important for the doctor not to get embroiled in sort of saying, well, there's 4 on one side and 5 on the other, or anything of that nature, or giving more weight to one side, because there shouldn't be sides in a case like that, of course. Everybody should be trying to find the best solution that's in the best interests of Mr. Sullivan. But I think the issue of the role of the family in decision making is very important, and it's something that I think doctors probably find very challenging in practice, because family members don't have any, and again I'm using legal terminology I suppose, but families don't have any legal role in making a decision. In this case for Mr. Sullivan, the doctor has the responsibility to decide what's in Mr. Sullivan's best interests. The reason that he would communicate with the family is to find out what Mr. Sullivan's own values and preferences and wishes might be in that situation, and so far as the family can give that sort of testimony, if you like. But ultimately he has to decide what's in the best interests, and not give the family the sense that they have a right to decide one way or the other. The obligation or the responsibility, the ethical responsibility is on the doctor. And I think it's all about, again, going back to what John was saying about communication and trying to ensure that the family go along with you, and to try and ensure that they understand the reality of the impending death of their father, and what can realistically be achieved. But I wouldn't get into 2 on one side and 6 on the other, or anything of that nature. I don't think would be advisable.
Dr. Ishtiak.
Sorry, I think John wanted to come in on that point.
Thank you, President.
Actually, sorry, Ashton, before you start, John, you wanted to make a comment as well, did you?
Well, it was just to add, because I do think it's an important point, and when we were talking about the previous scenario, someone in the audience made the very important point that there are services available in the community, because different doctors will feel able to involve themselves in this type of situation to greater or lesser extent, and seeking consensus can be very emotionally draining. We were hearing about the effect that can have on doctors earlier this morning. But it's also not something that we're necessarily very skilled in doing. So in taking forward the process that I think you've described, some doctors will feel able to take that quite a distance down the road of seeking consensus, but other doctors may need to be aware of their limitations and to seek to bring others into that equation at quite an early stage.
Okay. So, Assam.
Thank you, President. If we bring in the principle of modern professionalism and we take the team approach to the management of this particular patient, and that is hospital at home scenario, GPs play a very important vital role in care of all these patients. However, if a multidisciplinary team was involved in the care of this patient, which is an international standard for care of stroke patients, until the time when they pass away. The concerns here are patient can't swallow risk of aspiration. This patient requires a brief assessment and appropriate management, i.e. the risk of swallowing is not going to change whether it's at home or a hospital. This patient would require alternative method of feeding, and that then can be done at home, supported by an extended care system of stroke care, which unfortunately this country doesn't have currently.
Thank you. A question, a comment just at the back.
Pat McGettrick, Medical Council member. I just want to change the scenario a little bit in case we don't get around to talking about it. Let's suppose that Mr. Sullivan had written an advanced care directive. would it have any legal standing, or would it change the outcome for him and his family in any way in this country? So
that's a very good question. Advanced care directives or advanced treatment directives are certainly something that is we've mentioned in our guide. So as I'm talking to Deirdre, is that looking for the page? so perhaps Deirdre, you might like to issue the guidance on the advanced care directive.
Yeah, I mean, what the Council says about it is, I suppose, in recognition that there isn't a legal framework in Ireland at the moment for advanced healthcare directives, even though hopefully that might come with future legislation in the Mental Capacity Bill. So at the moment, there is no legal certainty about whether or not such a directive would carry any sort of enforceability or any legal recognition. But I think most lawyers would expect that if such an issue were to come before the court, once certain criteria were satisfied, the court would uphold it. So if, for example, it was clear that at the time that Mr. Sullivan made his advanced healthcare directive that he did have full capacity, he was informed about his condition, he knew what was likely to be sort of coming down the road towards him, and he made a choice in anticipation of the future care that he might require, and that the decision that he made and was reflected in the directive covers the situation exactly that has now arisen, so it's certainly directly relevant, and that there's no evidence that he has changed his mind in the intervening period. If, for example, the directive had been written 3 or 5 years ago, is there any evidence that he's changed his mind? So the Council does give sort of guidance around that and says that you should respect the right of patients to refuse medical treatment either contemporaneously at the time the decision has been made, or if it has been made in advance within the sort of criteria that I've mentioned.
So just to summarise, I think the case, I think the core issue is really one of sort of the capacity of Mr. Sullivan to make a decision about his future care. I think we've heard some discussion as to what the best interests of Mr. Sullivan would be, both in terms of his medical interests, but also in terms of the interest that in fact he would have indicated when he was able to make those kind of decisions. I think we've heard about communication and the importance of communication with the doctor, Dr. Dunlop, and also with the family. And also, I think we have heard about the options in terms of looking at that rather than looking at it as an either-or scenario, that perhaps the sort of a provision of maybe additional supports that might assist Mr. Sullivan to remain at home if that was deemed to be what he would have wanted. So Mrs. Ryan is an 87-year-old woman, and when she's seen by her GP, he notices, Dr. Walsh, he notices that she has bruising on her arms. And when he asks her about this bruising, it becomes apparent that Mrs. Ryan is living with her daughter, who has a lot of psychosocial stressors. Her husband has just left. She in her levels of distress, it appears that she has been hitting out at her mother. So Mrs. Ryan's daughter, Julie, has been drinking heavily, as I say, and she's obviously is someone who also needs some support at this time. So you, as Dr. Walsh, have to make a decision as to what you're going to do. So perhaps I might ask John this time to start off. So John.
Well, thank you. And this is one of the places where I haven't seen the guidance from the Council, but I do know what the UK Council would say, and I doubt if the principles are very different. Principles being, first of all, the importance of confidentiality and of patients being able to trust doctors not to make information available to others without their consent, except in carefully controlled circumstances. But one of the things that we say in our guidance to doctors on confidentiality is it may be appropriate to encourage patients to consent to disclosures you consider necessary for their protection and to warn them of the risk of refusing to consent, but you should usually abide by a competent adult's patient's refusal to consent, even if their decision leaves them but nobody else at risk of serious harm. And I think that's what we're saying to UK doctors in terms of having to make that judgment about the individual, their capacity to make the decision themselves, whether that decision is entirely about their care or whether there are risks possibly to others from the individual who's alleged to have undertaken these actions. And the doctor needs to try and very carefully and sensitively tease those things out, encouraging the individual, encouraging Mrs. Ryan to be prepared to be open about this and for a conversation to involve the other caregiver as well. But the bottom line, if the doctor judges that Mrs. Ryan is competent and she absolutely refuses, then the doctor cannot release that information, but can do the best they can to encourage Mrs. Ryan to perhaps seek help and support from other sources. And again, community resources would be the really important thing for this person to be aware of and to be pointed in that direction.
Thank you, John. Deirdre, can I ask you to comment?
Yeah, again, I suppose we would start from looking at the issue with the capacity, and there's no suggestion in this case that Mrs. Ryan is anything other than capable of making her own decisions. We're told that she's physically frail but mentally alert. Again, just to, I suppose, reiterate what John has said about the importance of confidentiality, which is essential to the relationship of trust between doctors and patients. Confidentiality always is a balance, though. I mean, confidentiality is not absolute. There may be circumstances, exceptional though they are, in which it is justifiable to breach confidentiality. There's a public interest, I suppose, in maintaining confidentiality because it maintains the trust of the public in the profession and in their own individual doctors. But there's also a public interest in disclosing information in certain circumstances to protect vulnerable people from harm. So it's about getting that balance right. So I suppose we'd first maybe try to support and enable and maybe empower Mrs. Ryan to make a decision that is in her own best interests, and as John said, to put her in contact with support groups, and maybe also to think that perhaps her daughter might need some respite from caring for Mrs. Ryan, and that maybe that would relieve some of the stress that she may be under, and that might alleviate some of the difficulties in the home. I suppose to encourage Mrs. Ryan to think about maybe seeking support, even if this does require her to disclose something unpleasant about her daughter, which she doesn't want to do. To warn Mrs. Ryan that maybe this might recur, this might not have been a once-off incident, or it might be something that might continue unless something is done to stop it. But ultimately, I suppose, if she is capable of making her own decision, and if she refuses any further support or discussion or disclosure, then it would have to be only in very exceptional circumstances, I think, where Dr. Walsh considers that she is at serious risk of serious harm or recurrence of serious harm, that it would be justifiable in those cases to breach her confidentiality to protect her. But that would be the last resort, I think.
Thank you, Deirdre. Margaret?
I'd hate to be the doctor in this situation, because at the end of the day, when he goes home at night, he has this knowledge. And what does he do with it? It is not the first time this has happened. The lady has said that it wasn't the first time exactly. So it is something that's ongoing. I see that in this household, there are two patients. There's the woman herself, and there is her daughter. And that daughter has had a considerable life change in the last 12 months. Her mother has come to live with her. Her husband has left her. And this doctor is the doctor for both of them. So I do think there is a role for him to explore in some way with Julie how things are going for her in the light of all that has happened in her life in the previous 12 months. And this incident came to his attention during a home visit. So during a home visit, he has the opportunity maybe to have a conversation with the daughter and to explore things further. Because I would hate to see things just left, and I would hate to see a doctor rely on an ethical guide and a confidentiality clause in an ethical guide if this particular woman did come to serious harm. Because while he might be exonerated by courts, by peers or whatever, his own conscience may not exonerate him because of this frail woman having come to harm. So it is a truly, truly difficult one.
Thank you. Comments from the floor? Stephen.
Thank you. I'd just like to endorse what Margaret has said there. I mean, the key issue here, you have an 87-year-old lady that doesn't have time for processes and, you know, lengthy consultations with other professionals around. And I think perhaps, I think the important takeaway from here would be that people actually have a strategy that they can actually action if they come across a situation like this, so that they're not actually, how would you say, inventing the wheel. Because what Margaret's saying there is the reality. And you know, even the suggestion to a carer that they haven't been looking after their parent or whoever is enough to maybe start or inflame things again. So I just want to make that point. Thank you.
Other comments? Yeah, Professor Dowd again.
I must say, listening to the cases and listening in particular to Margaret, I think it's a pity that because of all the cases that we describe ourselves as general practitioners, because there is another description of us which is as family doctors. And it's interesting that the cases have very firmly put the medical problems in the context of the family. And it's the only group really in Ireland that we have to rely on. It's the only, in many cases, and I think over the next 5 years it'll be the only people that will be in our corner really, our families. And general practitioners do have a lot of experience in dealing with family, what we used to call family doctoring, family medicine, but it has moved away towards perhaps doing things to people, where I do think that clearly these cases have highlighted very strongly that we do need to upskill ourselves or accord ourselves some kind of authority in the area of being doctors to families, because I quite agree that there are 2 patients in this household, and a lot of family doctoring is about tactics and strategies. This doctor has brought this on himself. He's gone in there and made an observation, and sometimes making an observation, you then have to think through that you're going to have to do something about it, and quite clearly he's now in a situation where he has to do something about it. But there are tactics and strategies that he can adopt. I suppose that's all the cases have highlighted that, and I think in our training perhaps we do need to emphasize those tactics and strategies just as much as the high-flown consents and breach of confidentiality and whatever. And there are tactics. There's nothing like stress in a family to bring out the worst in people, just as much as the best in people. And in this situation, it's the underbelly of life, clearly. And the daughter is under stress, and presumably will consult the GP anyway, because that's what people in distress, it's often the only place they have to go. So doctor, whoever it is, Dr. Ryan, has an opportunity obviously to talk to this person. But I go back to my point. I don't know if there's anything the Medical Council can do to help us actually restore our roles as family doctors, just as much as we are general doing things to people, practitioners.
Okay. Question? Yeah. So first Mariko, and then the lady behind.
Mariko, it brings me back to the discussion that was on earlier about the new professionalism. And one of the issues that came up in that was the idea that doctors work in a multidisciplinary team. And we've also spoken about the idea that GPs are often more isolated than the doctor, say, that's working in the hospital. I think it's critical in this type of scenario that the GP is also working in a multidisciplinary team, which includes the people like social work and other healthcare professionals. I think we only have to look at a really horrible scenario that we had in the southeastern part of this country a couple of years ago to see the public outcry that happens when somebody is left in a situation, a horrible situation, and there appears that nobody did anything about it. So I think we do have this absolute need to work in multidisciplinary teams and to link in with each other to provide the supports that families need in these kinds of scenarios.
Thanks. And the final question, just at the end.
it's probably more a comment. I've been thinking about Professor Rowland's comments about our payment system and how that sometimes very much influences our outcomes. I'm thinking about your question there. I think there's a link maybe, and I think they're trying to address it in the UK, in looking at outcomes. I mean, this situation could have very positive outcomes, but if you were doing a fee-for-service model, that he will find it very difficult to be a family doctor. Does that make sense? So I think we seriously need to think about this in our current climate and challenge toward outcome, okay? And that may help us be the kind of practitioners we want to be. Thank you.
Okay, so just to try and summarize, I suppose, the opinions that we've heard, the issues, I think, really relate to confidentiality. And as we've heard, that confidentiality isn't absolute. So there's the requirement for confidentiality in the patient-doctor relationship, but there's also the requirement in the public interest to ensure that the patient doesn't come to harm. And it's trying to, as a doctor, trying to balance those sometimes competing views with a view to actually what ultimately we have to do, which is to act in the patient's best interests.
The fourth one is a case of misdiagnosis, poor handovers, untimely action, and with the result that the patient dies. So the dilemma, and both an ethical dilemma and a societal dilemma, arises around disclosure. And the guide itself certainly recommends that disclosure and transparency are paramount with regard to professionalism, that there should first of all be acknowledgement that something happened. It's about the response following an adverse event, that there should be acknowledgement, that there should be an apology, that there should be an explanation to the family, to the patient, and that then there should be some evidence of learning. So I imagine that none of us will actually disagree with that. And I suppose what I am saying is that there are true benefits to disclosure. Disclosure has now become the new kid on the block. And the benefits accrue to the professional himself, who is, of course, devastated when he is maybe a contributing factor to an adverse event. So there are great benefits to himself around disclosure. There are benefits to the patient and the family in their recovery journey, because once they understand, they have some hope of healing and recovery. And of course, there are huge benefits to the system itself in the areas of learning and preventing of recurrence, because it is about issuing safe care, providing safe care. And I suppose, in summary, what I would say about disclosure is disclosure, and there was huge talk about professionalism this morning. Disclosure is not about blame. Disclosure is not about apportioning blame. It's not about accepting blame. It is about integrity, and it is certainly about being truly professional. And the Medical Council really recently undertook a survey which indicated, the responses to that actually indicated, that 88% of the respondents trust their doctors to tell the truth. Now that's awesome, it's wonderful, and it's a real indication of maybe experience in interactions with healthcare professionalism, but it does make it all the more unacceptable when that level of trust is betrayed. So they would be my summarising points around disclosure.
Okay, thank you, Margaret. So I think that because time has moved on, I'd like to thank our panel, both Deirdre, John and Margaret. I think it's been a very interesting session.